Welcome to Value-Based Voices, a podcast from the Association for Value-Based Cancer Care. Each episode dives into the shifting terrain of cancer care in the United States, exploring what value means in today's clinical, policy, and patient-centered environments. Our mission is to spark informed dialogue, promote transparency, and equip every stakeholder from providers to payers to patients with the insight they need to navigate cancer care with clarity, confidence, and purpose. Thank you, everybody, for joining us. My name is Jayson Slotnik. I'm one of the co-hosts here for Value-Based Voices. It is an honor to be joined again by my co-host, Brian Reid, who's going to take this time to introduce our guests. And Brian, take it away.
Thanks a lot, Jayson. Look, I'm really excited to be here because about a year ago, the organization CancerCare put out a really interesting report that quantified, I think for the first time with great depth, what exactly prior auths, utilization management, the kind of sand in the gears of care looked like for cancer patients. And I've really wanted to get some of the CancerCare folks on. So we're really fortunate today to have the folks behind what we're calling the red tape report. It has a much longer name, but that quantifies this problem. So we're here with Alexandra Zaleta. She's the lead author and the VP for Research and Insights at CancerCare, along with Kim Czubaruk, who's the VP for Policy. And they've really put together, I think, an extraordinary piece of work. And before we get into the actual bits, I want to make sure that Alexandra and Kim have a chance to describe both what CancerCare does as well as the genesis for this particular work. So why don't we start, Alexandra, with you?
Thanks, Brian, so much for having us here. We're really grateful for the opportunity to share about this work and about what we do at CancerCare. We're a national nonprofit advocacy and support organization. First and foremost, we're providing direct free support services to people living with and affected by cancer, including things like resource navigation, direct financial assistance, individual counseling, education, you name it. And alongside of that, we engage in research and advocacy because we're trying to create systems change and also do a better job at supporting people day to day as they try to live with cancer and navigate the realities of this disease.
I'll just add, to that introduction it's a large umbrella, but I'd say access really is at the forefront of all that CancerCare does for our clients to make sure that everybody has access to the most appropriate and innovative care that's available to treat their cancer.
I often tell people that coverage is not access, and prior auth is the prime example of that statement. They launch a drug and they think they're going to have great access just because they're covered, and that is clearly not the case.
So this is based on a survey of over 1,200 people with cancer and their experiences with their care journey. What's the top line?
The top line, Brian, is that utilization management is widespread, and unfortunately, it's creating real harms to patients and their families. That's really the crux of it. Prior authorization and other cost control strategies are affecting the vast majority of people living with cancer. We had 85% of people have to face prior auth to access their cancer treatments. 3/4 of that happened to them in the last year alone. And so the numbers are big, but again, it's not just the issue that it's widespread, it's that it's creating care delays, diagnosis delays, treatment delays. Patients and families themselves are having to roll up sleeves, get involved in this process in order to access their doctor prescribed care. And as a result, they're stressed. This is costing them money. It's affecting their trust in the healthcare system. So really big picture, we're dealing with a really difficult situation here, especially because most of these folks actually get their care approved in the end. It's only after they jump through all these hurdles and fight the fight in order for them to be able to access this treatment.
So a lot of theater here around proper utilization that in the end does nothing but add cost and burden to the system.
Yeah, I think that's the challenge. We have a lot of, there's been a lot of conversation about efficiency and systems waste. And I think we really struggle with a system that as implemented it's hard to make sense of it if you're putting the vast majority of folks through this process, but then you're also approving the vast majority of their care, but only after they're experiencing these personal harms. That's sort of a tough pill to swallow.
So can we go through the harms here, because you rattled off a half a dozen, and I think it's worth really digging into the heart of the report, which is what are these harms and what is the degree to which it's impacting this population. So again, 85% of folks are experiencing some of this, if not all of this. But let's start with, I think the ones that really caused me the most, pause, the clinical impact. What happens to coverage and what happens to your clinical care when you run into some of these barriers?
Yeah. I mean, I think just out the gate, the biggest challenge is that people are facing diagnostic delays and they're facing treatment access delays. That's the reality. Just when we ask about their most recent prior authorization, almost a third of folks saying that impacted the timeliness of their diagnosis, and 40% of folks saying that impacted the timeliness of their treatment. For some people, that time delay could be a few days or a week, but for about 1 in 5 folks, it was 3 to 4 weeks or even more than a month. And I think the pain point is people are going through this multiple times a year across every point in the care continuum. It's happening early on in diagnostic imaging. It's happening at biomarker testing. It's happening before they can access the chemo or the radiation or the immunotherapy. It's happening before they can access the supportive treatments to help them stay on their treatment, the pain medicine, the nausea medicine. So there's a real cumulative burden that I think is happening for people, because this is happening again across all these different touch points. And so each time it's happening, they're put in this position of delay in access.
And it's not like once you get yourself set up, you're free and clear either. You documented some coverage stoppages of patients who were on therapy, and then all of a sudden, what happened?
Yeah, I mean, I think that's the other half of the coin here, is that many people go through prior authorization. Some of them are primed. They've been through it before, or they may have been told about it, by their healthcare team. But what a number of people are also finding is that once they get access to that treatment and they're on that treatment, they're finding that their insurance is no longer covering the treatment. Not because they switched plans, not because they changed employers, but their existing coverage is saying, we're no longer going to provide coverage for the treatment that you're receiving. And so that translated to coverage stoppages and delays in access for many folks. Many of them had to change therapies, and we asked them, well, what happened when you switched to that other therapy? A number of them said, I actually had worse side effects or symptoms on the new therapy. And many of them said they actually had to pay more money once that shift was made. So, somebody may be saving costs in this process, but many times it's not people with cancer in their families.
Alexandra, are you able to expand upon the payer mix on some of those numbers? Did it differentiate between commercial payers and Medicare payers? Break it down for us.
It's a great question, Jason. So we focus this work specifically on folks with employer health plans, folks with Medicare Advantage, and folks with traditional Medicare. What I want to say out the gate is that no one is untouched by this process, but we saw the greatest impacts for folks on employer health plans. So people that are either working or they're on a plan for their loved one, most often were the ones reporting the most red tape that they had to navigate, and also reporting the most harms as a result of that. So greater stress, potentially more costs to them, again, loss of trust, all these other, real pain points. And again, it was true across these different plans, but unfortunately, folks with these employer plans most often reporting it. And what I'd mention is that in our study, the people on employer health plans were younger, but they also were sicker. These are more often folks with metastatic disease. So these people are living with advanced cancers. They're potentially the ones dealing with real health vulnerabilities. And now they have to tackle all of the stress of navigating, administrative barriers just to access the doctor prescribed care.
So speaking of doctor prescribed care, was there a difference in delay times between pharmacy benefit and medical benefit? Because to some extent that speaks to which part of the healthcare ecosystem is then advocating on behalf of the patient for access, whether it's the pharmacy or the physician. Did you look at it? Does the data get that granular related to benefit design?
Jayson, I always love these conversations because you give me new ideas for how to segment the data. So I have some ideas for what we can do with our next level analysis. We haven't diced it out exactly that way today. And some of the questions we want to ask in the follow-up work, we're planning actually a next generation study on this. So I don't have a direct answer for you today. What I can say is that that involvement differed for folks on Medicare and folks on employer plans. About a third of folks on Medicare having to get directly involved versus saying their doctor took care of everything for them versus about 2/3 of folks on employer plans who had to get involved having to navigate this process. So more people on employer health plans having to directly roll up their sleeves rather than having the doctor take care of the process for them.
So where Brian and I's minds are going is into that whole morose of PBM and accumulator and maximizer programs and how different those are, as you know, on the pharmacy side, and those are evolving into the medical side.
Yeah.
And that would be some really interesting information for our audience. So all this does is guarantee your next invitation, Alexandra.
Thank you, Jayson. Well, what I can tell you, and I know Kim will have some context, is that most people don't know what a PBM is. Most people do not know what a copay accumulator and maximizer are. We asked them. 3/4 of folks either never heard of it or they heard of it, but they have no idea how these things work. So from just a being able to be a self-advocate. I hate to put this on the shoulders of people with cancer, but the reality is you have to know how a system works in order to navigate a system. And that's one of the things that we take on here at CancerCare is trying to increase awareness and understanding of what these programs are, what PBMs are, how they work, so that patients and families are empowered to ask the right questions, to understand what their rights and what their options are, because most people it's not on their radar. They just are not digesting it or haven't heard of it in the ways that we in the field, have an awareness of.
Yeah, let's pull on those two strings, both the fact that this seems to be worse in employer coverage and the fact that there's a real policy pull through here with things like alternate funding, accumulators. Kim, take us through kind of what, specifically to the employer side, what are some of the policy solutions as you're building coalitions? Who are you looking to partner with here?
Sure. Let me just add, prior to getting to that front, that I think it was a surprise to many people that the employer coverage was the most challenging. It kind of goes against the dynamic in the past where, for the most part, employer coverage was considered a gold standard, the best coverage, the most robust plan that people had. And we see that changing. That dynamic has been changing for a while. I'll say that CancerCare leads a task force on alternative funding programs. So I was not surprised, many were, but because of my work on AFPs and the challenges with employers trying to cut the cost of care for their employees, I wasn't surprised that the employer-based care indeed presented the most challenges. Also, the copay accumulators and maximizers are something that CancerCare has been working on in our policy angle to educate patients, also bringing in, though, educating employers as well as healthcare providers. All of those stakeholders are very important. And then, of course, getting to policymakers. So as far as policy solutions or ideas for us to correct this is that, cancer does present an immediacy with the condition itself. It brings in a little bit of the 6 protected classes and why that is such an important policy to make sure that all or substantially all medications are available to those on Medicare. Cancer, somebody could have the exact same cancer diagnosis, but because of biology, staging, other factors, different treatments may or may not work, even with the same diagnosis. So it's very important that we make sure that all are substantially all much broader than the 6 protected classes for all cancer patients, whether they have employer insurance, Medicare, whether that be Medicare Advantage or traditional, and I'll bring in the Medicaid patients as well. Cancer is unique in that, and the research and innovation's been tremendous, but if it's not available in a timely, appropriate manner to people, then all that research and that knowledge really has been for naught.
So, but Kim, you mentioned the educational efforts that you guys undertook as it relates to this report, how was it received by the various listeners, right? The employer groups, the patient groups, the provider groups. And part two of that question is, you talk about surprises. What surprised you the most on some of those reactions?
So the reactions, I think people appreciated the report, the statistics, the numbers that come out of it are very important, but our role as in cancer care and as advocates for these patients is to go beyond just the numbers and the stats. We always, Alexandra, myself, and others at CancerCare, we always have to remind people, right? We're talking about whether it be prior auth or step therapy, and talking the mechanics of it, that it does not become a robotic mechanical process. These are real people. They're not well, they're not feeling well, they have a significant serious disease that they're trying to combat, and yet these challenges and barriers are put in front of them. And I think when we get to stats or numbers and surveys, sometimes overall as a system, it's easy to kind of just talk about those things and lose that very important connection that these are real people. So I think my second part of your question, what was most surprising in the reaction is people recognized it, but they didn't seem to jump on, okay, how can we fix it? It was an acknowledgement that it's a problem, but it was almost like pointing somewhere else as to where to fix it, where we really believe it's going to take alignment and community across stakeholders to really work together. We're not going to align on everything. We understand that, but we have to, and I believe there are absolutely points of alignment where we can work together that will improve the system. And most importantly, when we improve the system, it helps the people.
I mean, that's the mission of value-based cancer care, right? Is to get everybody under the same roof, our organization, and do just that. So I'll turn it over to Brian. I know you had a follow-up question there. Sorry to interrupt.
No, I think this is it's interesting, I think, to reflect on the history of utilization management more broadly. You know, there was a time where we assumed that certain classes were kind of beyond these games, that you saw more of it in primary care, where you had different options, and maybe you had a chance to try a second line or a third line therapy. But oncology was treated different. Orphan diseases for a long time were treated different. And what strikes me, and I'd love input from Alexandra or Kim, that we're now seeing these techniques used in rare cancers that we wouldn't have seen before. We're seeing step therapy, which is an entirely novel concept in some ways in oncology, that not only are we working to fix things, but we're also seeing something broken that wasn't necessarily broken. There's a little, now I'm off my soapbox now, but I'm kind of curious about the evolution of step therapy, which I know is a small portion of what you documented. But where are we with step therapy, and how do we begin walking that back to a place that's going to be more patient-friendly?
With STEP, like you're saying, it wasn't really applicable, wasn't applied to the oncology space previously. And I believe one reason is clinicians and oncologists were given, rightfully so, we would argue, great deference in the treatment of their patients. And over time, unfortunately, that deference, I think, has been imposed upon. And now clinicians are having to confront more from their end, administratively a burden for them. It's also, they may want to have a certain drug for their patient. And indeed, we found in a recent initiative that we did, Micro Insights, Macro Impact, we interviewed a number of patients with different types of insurance. They shared their stories. We had focus groups, a couple of videos, which I encourage people to go on the CancerCare website and review those videos. It makes it very personal, as cancer is. Cancer is very personal. But most often you hear a lot of the patients say, my doctor prescribed me medication, and yet somebody else outside said, no, sorry, you can't get that one until you use something else. And they were dumbfounded on how the expertise of their clinician was, overridden by somebody who is not an expert in that field. So, we really need to promote guidelines, NCCN guidelines, research for off-label use. Again, it's critical with cancer. Even, accelerated approvals, all those things in cancer have made the difference of life and death, where terminal conditions for many people are now chronic conditions and they live a full and complete life. So we want to make sure that people have access to that. And with STEP, in addition, there's maneuverings there within plans that now STEP is also being incorporated within prior authorization. So patients aren't sure, are they subject to STEP? Is it prior authorization? What's actually going on there? And of course, it's more challenging than for somebody to appeal or ask questions or try to work with their clinician to get the right medication if they're not even sure what's going on.
So, Alexandra, how do we move beyond this, right? We've done a great job the last couple of minutes describing the devolving access for patients. How do we reverse this tide? What should we be doing? Give us some advice to the community who's listening to us. What 2-3 things should we be focused on as a result of the information you guys have on how we go back to where coverage really is access?
Yeah. I mean, I think there's a few opportunities, Jayson, first, and to come back to the question earlier about the provider reaction. This resonates with the provider's experience. And so I think it's incumbent on advocacy and the provider organizations. We work with ASCO and others because they're doing this work from the provider perspective. Our story tells a very consistent story, but from the patient perspective. And so I think it's really important for the different organizations that are involved, that are collecting these insights and telling these stories. We need to continue to find ways to work together systematically, because this is not just a special interest problem for providers, right? This directly impacts patients and their families as well. And I think our perspectives are stronger together. We've been really fortunate to have great relationships with many of these organizations. And I think we can do more as we continue to work together and build a coherent story that explains why the system can't stand the way it is. And then I think the other part is, we continue to try to draw attention to this, because what I would say for many folks, especially on the employer side, is disbelief. I genuinely think there are many employers, folks working on that side, that are working very hard. This is a huge spend for employers. It's often the second biggest spend, right? Health benefits. I'd want to know, if I was spending all of this money as an employer and to give my employees fair benefits, and give them the coverage they deserve, to then find out that after spending all of that they're still facing these harms, that it's time away for them navigating these stressors. And so, I really believe we have an opportunity to come together. I do think there are a number of employers out there that are trying to do the right thing and may not fully understand these systems as implemented, because the claims data can't show some of these patient harms, right? That's why we do this work and collect patient stories, to help people understand what some of these hidden costs and hidden harms are of these systems as implemented. So I still think there's a tremendous opportunity in that space. I do think there are many organizations that are trying to do the right thing, but have continued opportunity to understand more, again, about how these programs work and what that really means for their workforce. And so that door is open. We would love to have those conversations. We continue to try to meet with folks in that space, because I think we can create change today if people have an understanding of what this means for their organization.
Well, Brian, looks like we have our next podcast. So we're going to get some employers on.
Fantastic. I think we should have Alexandra and Kim hold their feet to the fire too. I think that's, but the point is well taken, that there's certain things you can see in claim data and certain things that you can't. And if you're an employer, I think one of the more fascinating pieces of the report was you quantified this idea of time toxicity,
yes,
which I assure you does not show up in the claims data.
Correct.
But anyone who's been through this, whether it's cancer or elsewhere in the healthcare system, that's a real thing. So what's time toxicity and how bad is it?
Time toxicity is the time that you spend lost to fighting red tape and administrative burden rather than doing literally anything else. Number one, focusing on your own care, recovery, and treatment. Number two, focusing on your family and your loved ones. And number three, for many of these folks, focusing on work. We did ask them directly about the time spent navigating things like prior authorization. People are losing days to weeks of their lives. If you math it out across all the different treatments that people go through across a single year, people are losing between 2 to 3 weeks, 2 to 3 business weeks of their lives to this process. That's a problem. It's a problem just for any human to have to spend that much time fighting a system rather than focusing on their own care. And as an employer, I'd be really deeply concerned to know that my workforce was having to spend all of this time navigating these systems. We all know this happens during the business day. That's when you have to make the phone call to be able to talk to a human, you know? And so the reality is there's a lot of silent time being spent on these processes by folks, again, rather than any other priority that they have in their lives. And that's a problem. That's grinding folks down. And it also affects the providers, is the truth. They're my-charting their doctors about this. They're stressed out. And so the doctors and providers, the healthcare team also have a time toxicity. Our advisors have told us this because now they're not only navigating this process on the insurance side, they have to support, they're happy to support patients, but that's more time now helping to manage that distress for them rather than being able to focus on clinical care, you know, followed by everything else.
And I feel like it's worth mentioning once again that 95% of these denials are eventually overcome, that all of this cost is occurring. And in the end, everyone ends up kind of back where they started with, which is in some ways great news, but in other ways, to lose 2-3 weeks of your life fighting something where the outcome should have been known on moment one is agonizing in its own special U.S. way.
So one of the
waste.
solutions we heard, Kim, one of the solutions we heard, I think it was from you, was, Alexandra, about education, right? The employers may not even understand the magnitude of the problem. CMS a few years ago talked about like a gold carding policy. So as we head towards the end here, give us some ideas on how we can fix this. Is it gold carding? Explain what it is. Is that what it is? The education and combination. What else should we be pushing for on the employer side, right? Because that's not really a policy solution. We can talk a little bit, maybe not, but that'll take a while. What can we be doing tomorrow to promote and get better access?
On the employer side, specifically self-funded plans, because about 67% of people who get their coverage from their employer are on a self-funded plan. And as many people know that are in this field, there's a lot of flexibility that goes with a self-funded plan, and employers actually choose self-funding because they like that flexibility. So ideally, that flexibility will be used to get treatments, the most appropriate, innovative treatments to patients quicker versus that flexibility where you have a TPA that's implementing as if you were a fully funded plan and implementing all of these delays. So I would love to see employers use that flexibility for good, step outside maybe what a TPA recommends. And yeah, it's time consuming and, you know, people are in other businesses, but there's the opportunity to actually, with those flexibilities, do the right thing. And I truly believe that when you get that treatment quicker, the most appropriate treatment quicker to your employee, everybody wins. The employer wins, the employee wins, and there's less waste for the system itself. So I would like to embolden employers who are in self-funded plans to take that action and really get more involved and don't just accept what another entity tells them to do.
Yeah. And Jayson, CancerCare developed a toolkit really to support folks on the benefit design side who, if they want additional insights or information about how some of the basics of this works, that's available to them. We tried to create a plain language summary. We have patient videos and testimonials that actually predates the red tape report because that's, you know, this has been a consistent and growing problem, but we're trying to offer the basics so that folks who want to have that access and can understand these issues so they can take that conversation internally and see where can they move the needle. You know, we do want to continue to promote that so folks have the opportunity to have that awareness.
Sorry, just going to add with step therapy too. We would love to see and coverage in general. Once a patient is on a treatment and it is working well, to have that change, where even if their insurance does change, where Alexandra spoke about in the report, where people who didn't change their insurance had the coverage, their treatment stopped. But even when somebody perhaps switch jobs or they choose a different plan, if they are stable and if that treatment is working, to be able to stay on that treatment, that is just it's so common sense. It's so important. We all talk about making sure patients are at the center and everything, really goes around what's best for patients. If we're going to be true to that versus just saying those words, that is such a common sense thing that should be done and implemented.
So we've kind of touched on a number of policy solutions kind of across the board. I want to make sure that you have an opportunity to kind of pull this together. What does this look like as you again look for partners, look for allies, look for coalition partners? What are the four corners of a reform regime that would work for employers, that would work for Medicare patients? Is there, because you had mentioned, no mid treatment changes, streamlining. What else falls under that rubric?
I would love to see, and this speaks to the employer insurance, but currently for employers to implement a medical exception process, that their formulary may be such and established, and they don't have to, self-funded plans don't have to cover any medications at all, although you want to retain a good workforce. That would be very challenging to do that, but most of course do, because they do want the quality employees to serve their business interest. But I would love to see more employers have, if a drug is not covered, to have a medical exception process. Some do, but self-funded plans, the current reading of regs and everything else is that they're not required to. So I think that would go a long way, because we have to remember employees are paying really good money for their employer plans. And yet, if they're not getting access to chemotherapy and other cancer treatments, getting prompt diagnosis, it's not working. And in the end, I truly believe this, in the end, for the employer sponsored care anyway, it has to work for both the employer, and they are real challenges and cost, but it also has to work for the employee. It has to work for both. And if it doesn't, it gets off balance. And for those who want to make sure that the employer sponsored coverage remains our primary system, I think we need to address this. We can't ignore it anymore. People have to get coverage for a serious condition, and employers have to be able to afford that coverage. So aligning with employer groups, employers, whether they're fully funded or self-funded, bringing in all the stakeholders and having honest conversations and identifying areas of alignment. And I think there are many. We just need to get all the right players, and really a large group of players into the same room, and let's have a really good, heartfelt conversation about this.
So, Alexandra, that gives you the final word here, right? That was a great segue with Kim, right? We spent the first part of our conversation talking about how we've gotten out of balance on access, right, with utilization management tools. And so now, when I agree with her, right? It can't be access to everything unfettered. There is an appropriate balance here. Give us some specifics. If you're running an HR or you're an HR consultant and you're sitting down with GE and they're doing their benefit design, what is the perfect balance, given your level of expertise here, that you would advise for a self-insured employer group? And then maybe we see if we can start an education campaign around that.
Yeah. Jayson, my answer is I don't know. That's why we want to work with these folks. That's the truth. We genuinely, we're not here with the perfect solution. What we're here with the opportunity. I know that there's a lot of really challenging data here, but for me, what it does is it creates the opportunity for change. We have to take action. The system cannot stay the way it is. We're ready to sit down and work with folks and have that hard conversation. We're looking for the champion who's willing to come to the table, right? Where's that one large employer? Like, those are real lives changed when you get someone on board. And we all know it's hard to be the first, but once somebody gets on board, that opens the door for others. to rethink how things are looking. So I don't mean to be Pollyanna about this, but we're not going to create change unless we can make something that takes in the perspectives of the different sides. And we want to have that conversation. We're ready to sit down. I'm confident provider groups, would be open to this conversation. It's time to find somebody that is willing to take that really hard step, but say, where can we find the common ground? How can we evolve this system?
So Brian, challenge accepted, right? We've got to go find.
Yeah, I've got some hard questions that to ask of the self-funded employers of America. From a data standpoint, what's next for the red tape report? Obviously, you've got a trove of information now. You can always grab longitudinal data and do it later. But what are some of the unanswered questions, even after you've gone through all this, that we should be trying to answer? And I don't want to put this all on you. There's a great research community that I'm hoping is going to pull along as well. What are the questions folks should be asking?
For us, it's really this conversation again about these hidden costs and hidden harms. I think this time toxicity piece, what this really means for folks and what they're dealing with, and how do we continue to shed light on the challenges of what people, especially with employer health plans, are facing. I hope we'll continue to create more persuasive talking points and understanding in that community. As Kim shared, this report, it was really big. We covered a lot of turf. I was surprised by the depth and the complexity of what we saw in the employer health space. So, and we'd love to have those folks come on board and help us create that project and do that work together, but it really is coming in and understanding, what does this mean for folks with their productivity? What does this mean for their ability to continue on with their roles? Again, you have this big upfront spend. Many of these programs are promising to save costs somewhere, but the concern is we're passing on these hidden costs, these hidden impacts that actually really have tangible impact on employees. And therefore, indirectly, it comes back. It does affect the bottom line when people are spending time, effort, and energy, and this can affect things like retention, productivity. So I think there continues to be an opportunity in this space. It is a hot topic. I'm seeing folks, there's a lot of conversation around administrative burden, but I think specifically within that employer health plan space, and that's where Kim and I are continuing to work together to do that additional work, but also to can do the education at the same time and in parallel, because many folks, including professionals, don't understand the basics. They don't know the difference between a self-funded or a fully funded program and what that means for their rights, for their options, for benefit design. So we continue to push forward, and I think there's a lot of opportunity really within that space.
Well, I think you're doing one other thing well, which is there's also the piece of amplifying those patient voices.
Yeah. Yes.
And CancerCare has done a good job of showing what this means for an actual individual patient in a qualitative, this is how it impacts my life POV.
I just wanted to add one thing. I know we've mentioned it in passing, but I want to make sure it doesn't get lost, is caregivers. Because you might be an employer to a caregiver. That person may not be the individual with cancer, but their loved one has cancer. And the caregivers take on a significant amount of the responsibility working with their loved one. So caregivers also have that time toxicity and that lost productivity. So it's important for employers both to consider, the caregiver element as well as if their employee is the patient.
It's a great call out, Ken. We didn't have their voices directly in the red tape report, and our goal is to have their voices directly in this next generation work.
Yeah. So it sounds like we've learned a lot today, right? We learned a lot about the problem. Thank you guys for documenting that in your initial report. And from there, we've learned about some more work that needs to be done, right? By benefit design, whether it's pharmacy, medical benefit, and more about time toxicity. And some of the common themes that have been around since I've been in the healthcare is continuing to educate, make people understand, hope they do understand the impacts of the actions that they are taking. It sounds like we should be partnering and getting closer to the employer groups, and then by extension to some of the policymakers that oversee and regulate those policies. Department of Labor is in the process of doing that, and CMS is. So there will be some upcoming opportunities for greater education and mass education, I guess, on that. So I really appreciate all the learnings I've gotten today. Thank you guys for your time. I'm going to turn over to Brian and then you guys to give your final comments and what next steps are.
I'm going to leave this here. This was really fantastic conversation. I just want to make sure that Kim and Alexandra have an opportunity to tell people where they can find more information and what they can get. Because again, CancerCare has pumped out a tremendous amount of resources, and to the extent to which we can drop some breadcrumbs, I think that'd be a great service.
Well, we have a great website. Actually, it just relaunched today. We had one and we've made some updates, so it's perfect timing. CancerCare.org. You'll find the full red tape report as well as a 2-pager, which captures the highlights. We also have a policy and advocacy tab, which gets into our work in alternative funding programs, access in general, 340B, and other. All these things, though, are very patient focused. So we invite you to go to the website. There's patient videos, again, to bring home. And always remember that behind these studies and surveys and stats are real people. And we really want to make sure that the tremendous innovation is available to people who have cancer.
And Kim and I are available to meet with folks. We are happy to sit down, have a conversation, talk about the learnings. If there's, folks at your organization that could benefit from learning about these insights and the work that we're doing, we'd love that opportunity.
Well, thank you everybody for your time. We really appreciate your insights. We look forward to the future updates of the Red Tape Report. So thank you all. Make sure everybody visit the website and have the good rest of your day.
Thank you so much.
Stay cool out there.
That wraps up this episode of Value-Based Voices, brought to you by the Association for Value-Based Cancer Care. Thank you, Brian, Alexandra, and Kim for sharing your insights, and to you, our listeners, for joining the conversation. We look forward to the next update of the CancerCare's Red Tape Report with some more insights and guidance on how we together can collaborate and promote appropriate access to oncology therapies. If you found today's discussion thought-provoking, be sure to subscribe to Value-Based Voices wherever you get your podcasts. Stay tuned for more episodes that spotlight the voices shaping the future of oncology.